So the duodenal ulcers, we said that the developmental factors, the H. pylori infection, in which the toxins and enzymes that will promote inflammation and ulceration. The symptoms usually occurs in 1 to 3 hours after meal, and the pain will be experienced as worse and more intensified when the stomach is empty. So the blood, in terms of the bleeding that that will take place, is that it's a bright red blood, and if the patient vomits, like the hematoemesis, and then if the blood in the stool comes in, like through the stool, that will be black tarry blood. The gastric ulcers, the symptoms that will be pain may be relieved after food or may continue after a meal. Patient will have anorexia, weight loss, vomiting. And the pathophysiology, in addition to what we have here on the slides, that the gastric secretion tend to be normal or less than normal. The defensive factors, we have mucus, bicarbonate, blood flow, prostaglandin type E2. The mucus, which will form as a barrier to protect the underlying cells from the acid and the pepsin. The bicarb, most remains trapped in the mucus layer to neutralize the hydrogen ions that will penetrate the mucus. And the prostaglandin type E2, and we know from previous lectures that the NSAIDs will inhibit the secretion of prostaglandin E2, which is protective mechanism. So that will stimulate the secretion of mucus and bicarbonate of prostaglandin. And the NSAIDs that will inhibit the prostaglandin E2. That's why patients with on a chronic or long-term use of NSAIDs may develop the peptic ulcer disease. So the aggressive factors, there should be a balance between these two factors. So aggressive factors would be like the H. pylori, which lives between the epithelial cells and the mucus barriers. That's why it's very challenging. It's very tricky and very complex. It's tough to treat the H. pylori, and that's the challenge of the H. pylori, because the H. pylori, it lives between the epithelial cells and the mucus barriers. So it will escape the destruction by the acid, or the destructive effect by the acid. So half of the world is infected with this H. pylori, but most people, they do not develop the symptomatic or symptoms of the peptic ulcer disease from that. So the duodenal ulcers are much more common among people with H. pylori infection than among people who are not infected with H. pylori. So we said the aggressive factors, also the NSAIDs, and we explained why. Gastric acid, increased acid alone does not increase ulcers, but is a definite factor in PUD. Pepsin, smoking. The infection with H. pylori is the most common cause of gastric and duodenal ulcers. Additional factors must be involved, like 50% will harbor the H. pylori, but only 10% of that would develop the peptic ulcer disease. Also, there are some risk factors like familial, drugs, blood type, smoking, caffeine, stress. So we have also 3 different types of what's called stress ulcers: ischemic ulcers, Crohn's ulcers, or Cushing ulcers. The stress-related mucosal disease, which is the stress ulcers, that's an acute form of peptic ulcer that tends to accompany severe illness, systemic trauma, neural injury. The emotional stress may also cause peptic ulcers. Ischemic ulcers develop within hours or of even such like, there is a hemorrhage, multi-system trauma, severe burns, heart failure, sepsis that cause ischemia of the stomach and the duodenal mucosa. And those that would develop as, in terms of the burn, that was called Curling's ulcers. So the Curling ulcers, that's the type of ulcers that would develop as a result of burn injury, called Curling's ulcer. And then the Cushing ulcers, that's the ulcer associated with severe head trauma, brain surgery, that would result from decreased mucosal blood flow and hypersecretion of acid caused by overstimulation of the vagal nuclei. So the primary clinical manifestation of stress-related mucosal disease is bleeding. Disorders of motility, we have GERD disease, which would develop when the LES zone pressure falls below normal. Conditions that increase abdominal pressure can contribute to the GERD. And these are some manifestations in which that the abdominal pain that would be experienced within like an hour of eating, within 1 hour of eating, that is a sign of GERD disease. The acidic stomach content move up into the esophagus, cause intense burning, the heartburn. That's why you call this this as or disclose it, or expressed as a heartburn, or experienced by patients with GERD disease as a heartburn, and that may lead to the esophageal ulcers, esophagitis, or strictures. Treatment will include combination of lifestyle changes or modifications and pharmacotherapy. That will be the best strategy or modality to treat this disease. Combination of lifestyle changes and and pharmacotherapy. So GERD drug classes, we have proton pump inhibitors, we have H2 receptor blockers, and we have the antacids. So the goals of the drug therapy: alleviate symptoms, promote healing, prevent complications, prevent reoccurrences or recurrences. The proton pump inhibitors, PPIs. So it's critical that we evaluate also the therapy. That to keep in mind is that the cessation of pain and disappearance of ulcer rarely coincide. Cessation of pain and the disappearance of the ulcer rarely coincide. So pain may subside before complete healing or may continue after healing. So the most effective drug for suppressing the secretions of the gastric acid is the proton pump inhibitors, the PPIs, and it's well-tolerated medication. It's the selection of the PPI. We have too many PPIs, so the selection of the PPI drug would be based on the cost and the prescriber's discretion or the preference of the prescriber. So the mechanism of action: it blocks the gastric acid secretion by binding irreversibly to the HK plus ATPase enzyme at the surface of the parietal cells. So it will block the final step in the acid production of that secretion. We have omeprazole, Prilosec, it's the prototype drug. Recommendations not to be used for long term, even though that's patients are using that for long term right nowadays. But it's the recommendation. It's usually recommended for to be used for up to 8 weeks of therapy for peptic ulcer disease and GERD disease. Other types of PPIs like Nexium, Prevacid. The second group of drugs is the H2 receptor antagonist. We have the ranitidine, which is Zantac, which is the prototype drug, and it blocks the H2 receptor in the stomach, and it will decrease the acid production. So that's the mechanism of action. It's the first choice of drug for treating gastric and duodenal ulcers. All right, so the H2 receptor antagonist, we said that's the first choice of drug to treat gastric and duodenal ulcers. It will promote healing by suppressing the secretion of gastric acid. So we have we have four different or other types of or medications that belong to this group, and all four are equally effective. And but some of them, they have fewer adverse effects than the Zantac. Okay. Zantac also, or ranitidine, can be effective for other than just the PUD and prophylaxis for the PUD, recurrence of the PUD, but also, and GERD, it can be it can be used to treat Zollinger-Ellison syndrome, which is a condition in which there is an increased production of the hormone gastrin. So the gastrin hormone, increased production of this gastrin hormone, will lead to this Zollinger-Ellison syndrome. And usually there is a small tumor like gastrinoma in the pancreas or small intestine that will produce a high level of gastrin in the blood, which would result in Zollinger-Ellison syndrome. So So just gonna go back to the antacids. Okay. To the H2 receptor blockers or antagonists. The H2 receptor antagonists, we have other types, just like cimetidine, tagamet, in which that it's good again for the gastric and duodenal ulcers, for GERD, for Zollinger-Ellison syndrome, for aspiration pneumonitis, for the heartburns, for acid indigestion, and it will. Some of the side effects are the CNS effect, sometimes will result in pneumonia. Pepsid or famotidine, another drug under this group. The difference between the cimetidine has androgenic effect and weight loss, and when we take the drug in high doses. So anti-adrenergic, androgenic effect, which is a hormonal effect, androgen receptor. However, the famotidine does not have that effect. So it doesn't bind to the androgen receptors like the Tagamet, cimetidine. Cimetidine, the drug will bind to the androgen effects, so it will have anti-androgenic effect when it's taken on large or high doses. However, that the peptide or famotidine does not bind to the androgen receptors, so that is not present in this drug as a side effect. Antacids, the third group of meds that it will, so the antacid will react with the gastric acid to neutralize it, neutralize the salt and make it less acidic, decrease the destruction of the GI tract wall by neutralizing the acid, and it may enhance the mucosal protection by stimulating the production of the prostaglandin E type 2. So we should be careful with when we give that to the patients with renal impairment, like patients with end-stage disease should not get, a drug with aluminum substance. H. pylori, the treatment for H. pylori is we usually treat it with a combination of a minimum of 2 antibiotics to decrease the risk of developing that. So because the recurrence of this disease, the problem, the most challenging aspect of this disease is the reoccurrence of the disease. So that's why we will combine more than one antibiotic to treat the H. pylori. And these are some medications that we will combine. There are different packages or like a therapeutic modalities in which that we can use, like triple therapy, quadruple therapy, or even we have 3 drugs or more than 3 drugs can be given as an antibiotic at the same time in combination to treat H. pylori. It's very challenging to treat this disease. And these are some of the questions with answers, and that's it for this lecture.